Hi, everyone. Thanks for joining us today. We have a really great event planned for you all. My name is Jennifer Oyoung. I'm a second year student at the Graduate School of Business, and have had the great pleasure of collaborating with Gianni and others on the Stanford Psychedelic Science Group. I also had the great pleasure of meeting with Dr. Peter Hendricks a few weeks ago to discuss his research on psilocybin-assisted psychotherapy for cocaine dependence. And I'm so excited for him to share some of the initial observations and for joining us today. Gianni is going to be moderating per usual, Grandmaster moderator. And so I'll hand things back to you.
Awesome. Yeah, thanks, Jen. And thanks, Dr. Hendricks, for coming. I was just going to give like a super short intro, and then if you wanted to say any more about yourself and your career, please do. Like I said, I've been a fan of your work for a while. I think what I appreciate most about what you do and what you bring is that you've worked in addiction for, I think, 2 decades, and so long before psychedelics and psychedelic therapy became all the rage, you were trying to help people who are suffering from substance use disorders in different populations who are vulnerable. So you have a really good context for coming to psilocybin therapy. I think that's not part of this psychedelic evangelist. I think you have a strong grounding in clinical psychology and research. And the other thing is that you brought to the field these massive observational studies that made these linkages between psychedelic use and reduced rates of recidivism in people in the criminal justice system, and at large in the population, associated with reduced suicidality. And that's building on some of the early work, but doing it in a way that complements these small pilot studies and randomized controlled trials. And you approach it from another angle, which is proposing this idea of awe as this construct that's central to the experience. So just really appreciate all of the angles that you bring to this. And that's to say nothing about it's kind of truly a pioneer in the sense of applying this to a population which, has not typically been, privileged to have psychedelic therapy. So we'll hear all about that, but really appreciate you coming. Super excited to hear this presentation, and I'll hand it over to you, Dr. Hendricks.
Well, Gianni, thank you very much. That was extraordinarily kind. I don't have a lot to say, but I'm very grateful for that introduction, and I'm very happy to be talking to you all. So as I go through this, please, if anybody has any questions, I don't know how we'll moderate this, but feel free to interrupt as we go. The trial that I'll be discussing is a little complicated, and this presentation is not quite as refined as it could be, in part because these are our preliminary findings. So if anything doesn't quite track, feel free to interrupt with any questions. As I was discussing with Gianni and Jennifer beforehand, I'm a big believer in open science. So I'm very happy to answer any questions at any point. If anybody's interested in seeing our treatment protocol, our therapy manual, or have any questions about how we're doing this, I'm very happy to share. I hope that as this field moves forward, that we're all very open with each other and happy to collaborate. And right now, I think the field is very cooperative, and I'm happy to see that. I think we'll all accomplish much more the more cooperative we are, which, funny enough, seems to be something at the heart of these transcendent type experiences, is that people tend to think a little bit less of themselves and more of how they integrate into the collective, and how they can serve others or the collective more so than themselves. In any event, I thought it'd be fun to talk a little bit about history. We almost always get these brief history lessons when we talk about psychedelics, in part because the history is so interesting and somewhat odd. So I won't really repeat what most of you probably already know, but I wanted to mention a little bit here. So on the left, we have Richard Alpert, who later became Baba Ram Dass. And I'm sure many of you know that he is a Stanford graduate. And by the way, excuse me, there's a small school here in Birmingham called Samford. And when I moved here from San Francisco, it took a while to learn to say Samford, and now I might accidentally do so. I know I'm talking to Stanford. In any event, many of you probably know that Richard Alpert received his doctorate from Stanford in 1957. And funny enough, Timothy Leary here on the right, not many people know, received his doctorate from the University of Alabama. Not the University of Alabama at Birmingham, which is where I am. And something that Jennifer and I discussed beforehand is that's a different university. So University of Alabama to UAB might be much like what UC Berkeley and UC Davis are to one another. So they're both part of the UA system, but different campuses. But in any event, Timothy Leary was, as I understand it, expelled from West Point and then was nearly expelled from the University of Alabama for sneaking into the women's dorms. But later was able to complete his degree via correspondence. So there is an interesting Alabama and Stanford connection here historically. Many of you probably know two of these gentlemen did some research at Harvard with psychedelics, though it's hard to really see as you go through the literature what they may have contributed. I think the book they wrote together, The Psychedelic Experience, was really brilliant and beautiful. And these are two extraordinarily brilliant and charismatic people. I would do anything to have just a little bit of their intelligence and charisma, though there's not a great deal of scientific output, but I still think that, we owe them a debt of gratitude. Also a bit of history. Here are two gentlemen that many of you may not recognize. And if we were in a proper auditorium, I could interact with you and see if anyone knows. But on the left, we have Humphrey Osmond. And hopefully many of you have heard of Humphrey Osmond because he was a true pioneer, having worked with Hoffer in Canada on the development of LSD and the treatment of alcohol dependence. And it was Humphrey Osmond here on the left who coined the term psychedelic. Humphrey Osmond administered mescaline to Aldous Huxley, and they had an exchange where Aldous Huxley thought the term phenerothime, I think, would be a good label for psychedelics. And Humphrey Osmond responded via letters at the time. This is, I guess, in the 50s or early 60s, that no, psychedelic is a much better term. So Humphrey Osmond coined this term. And on the right, we have John Smithies, who was one of his colleagues, perhaps lesser known, but John Smithies really encouraged Humphrey to explore mescaline and then later LSD. And apparently Smithies and Humphrey would often, before moving to North America, would gather at apartments in London and sort of explore personally the effects of mescaline with Aldous Huxley. Funny enough, Humphrey Osmond and John Smithies, the two were both here at UAB. Humphrey Osmond's last academic placement was here at UAB, where after psychedelics were placed in Schedule 1, he became a schizophrenia researcher, which he really was beforehand. And John Smithies continued to work primarily in schizophrenia, and only passed away about a year or so ago, and was publishing well into his late 90s. And he passed away, I think, at the age of 98. So we have some interesting connections here in Alabama. And there are some colleagues I have here at UAB who knew Humphrey near the end of his career. So, a little bit about the current study. And I'll add a personal note after I discuss this briefly. My own background is in smoking cessation. And before starting graduate school in Tampa at the University of South Florida, I worked at a homeless shelter in the Tenderloin in San Francisco. And one common thread for many of the residents of the shelter, it was a longer term shelter for families, was addiction. It seemed to be either, a primary cause or certainly something that exacerbated their situation. So I was interested in studying addiction and helping to develop better treatments for addiction. Though smoking was never necessarily my focus, my graduate mentor at the time argued that, look, if you want to understand addiction, this is a great model. If you want to actually finish graduate school, it's even better because there are a good number of smokers out there at the time. 25% of the population smoked. So they're not difficult to recruit, and they generally are a bit more reliable. And boy, have I learned that through personal experience. The cocaine using population is challenging, to say the least. So here's a meta-analysis my postdoc and I recently published on dropout rates in clinical trials targeting substance use disorders. And here you'll see that studies that targeted substance use disorder were associated with a nearly 50% dropout rate. And if you look across really the major stimulants, you'll see that that's really where the dropout rates are quite high. So hovering around 50% for methamphetamine, and then major stimulants, broadly speaking, again, close to 50%. A big part of that is that major stimulants disrupt executive functioning. So long-term planning can be very difficult. And coming to receive treatment on a regular basis can be a big challenge for this population. And I think in this case, as I'll discuss a bit, given this sort of unique nature of psilocybin-facilitated psychotherapy, dropout attrition is something of a problem. And that's something we'll have to address as the field goes forward. But to speak to cocaine more broadly, not only do we have a problem with attrition in general, there are no approved pharmacotherapies. We have approved pharmacotherapies for tobacco, for alcohol, for opioids, major stimulants, even cannabis. There are some promising pharmacotherapies, but major stimulants seem to be that one very difficult nut to crack, right? We just don't have any pharmacotherapies here at all, and we need one. There have been many dozens of pharmacotherapies tested, nothing that's FDA approved. So that was one reason we want to address cocaine here. Another thing I should mention is that in some prior analyses that we conducted here in the criminal justice system, we found that cocaine use is one of the stronger, if not strongest, predictors of recidivism. And again, it makes sense. This is a major stimulant. So when you use the drug, you are up and moving, you are doing things, you're making bad decisions. And it's a very addictive substance. So people will, engage in some compulsive behavior to obtain the drug. So, with the eye on perhaps ultimately moving this treatment modality or paradigm into the criminal justice system, we wanted to target a substance that we knew would be very relevant for that population. And cocaine use, at least here in Birmingham, seems to be very relevant. Before talking about the current study, I want to add a little more, and let's see how this goes. I'm going to very briefly share another PowerPoint presentation. I just decided sort of last second to share this with everybody. So hopefully there aren't any big glitches in how this works, but let's see. Okay.
Well, while you're switching that, Peter, I'll just say that if anyone has questions, I can field them in the chat, and then, feel free to also to pop in, but then we can have maybe a few minutes for Q&A afterward if you have time.
Yeah, oh yeah. I tried not to go on for too long here. So can everybody see my PowerPoint presentation?
Yes.
So the psychedelic renaissance. So this is something that always sort of gives me a tickle. People have asked, why am I interested in psychedelics? I think often the expectation, I'm sure Gianni and others are used to this, is that I've got this extensive personal history, and that's why I'm interested. I like many of us who work in the area, just don't comment on my own history because there's no way I can answer that question that would satisfy everybody. I could say, no, I haven't. And a number of people would say, well, then you're clueless and have no business administering the drug. I could say, yes, I have. And then the response would be, I have no objectivity. And also, by the way, I've admitted to breaking a law. And that's not a good look for a public employee in a relatively conservative state. So no comment there. But this is something I love to share. So this was Roland Griffith's now hallmark article on psilocybin in healthy volunteers. And if you look in the top left corner, you'll see this was published in the journal Psychopharmacology in 2006. And the journal issue was 187. So as a postdoc at UCSF, I had published one of my very first articles on the early time course of smoking withdrawal. It's okay if you've forgotten already what that is. It wasn't super interesting, but I hadn't seen my name in print much at the time, and I was sent a complimentary copy to my little office, which is about the size of a closet, and I was really eager to see my name in print, so I sort of, opened this article eagerly, and note, here's my dissertation. Same journal, same year, same issue. And instead of opening to this article, I'll go back, I opened to Roland's. And I had to stop what I was doing at that moment. right? I had to read this article because, I should say, I'm from the Washington, D.C. area. My father was an attorney for the Department of Justice, and I was raised in the 80s during the height of the war on drugs, you might say, or at least the Just Say No campaign. And I internalized this idea that if the substance is illegal, if it's Schedule 1, if it's been deemed dangerous and addictive by the government, then it must be. And as a graduate student, there's very little training. There's very little education on what happened in the 60s, but generally the thought is, yeah, LSD, that was kind of weird, but let's just move on from that. And upon seeing this, I was really just, mesmerized, you might say, and really wanted to learn more about this. And reading the older literature, I was just fascinated and wondered how we've moved past this without really giving it a better look. This just really opened my eyes to an entirely new line of work that, I had not been trained in, informed on at all. And my first thought was there are obvious applications here to addiction. And if you work in addiction, some of you probably do, like I do, then it can be really frustrating. Take smoking, for example. I could give 100 smokers the very best treatment money can buy, pharmacotherapy and intensive behavioral intervention. And if 30 of those people quit smoking, we've been successful. And that's really demoralizing, because people who go into this line of work, like I'm sure anybody here, want to help others. We want to make a difference. And, after a while, you feel like the contributions or the gains are just incremental, and you want to see something that works better. And when coming across this line of work, my first thought was, hey, this could be a real game changer. This could get our abstinence rates up to, 50, 60% or higher, where we could really see big changes, save lives. And at the time, I brought this idea to my postdoctoral mentor at UCSF, who I'm very grateful to, and I'm still close to this day. But she had a hearty laugh when I suggest we do this work at UCSF, and told me, why don't you pursue that line of work when you're on your own? And not in San Francisco. She had this idea that if we did this work in San Francisco, that we'd just be playing into stereotypes. And I don't know if that's something that you've had to contend with at Stanford, but certainly the Bay Area has, a reputation. But I think we're beginning to see a change. And, the idea now is that there are some sober, objective, dispassionate scientists who are pursuing this line of work, not, dreadlocked, hacky sack playing hippies. Not that there's anything wrong with that at all. But, these sort of stigmatized perceptions of people who are interested in this line of work, I think, have fallen by the wayside. And we're realizing there's a lot of good that we can do. So let me go back to that other presentation now. I'm going to stop that share and get back to this one. Okay. So everybody can see the slideshow again? Okay. Yep. So in this pilot trial, we are evaluating psilocybin-facilitated psychotherapy for cocaine dependence. We have a target N of 40, and we've reached 30, which has really been a Herculean effort when you consider that we have a shoestring budget, and everybody who's working on the study is donating their time. And I'm sure an audience at Stanford can appreciate at a institution that is very pretentious with regard to grant funding, working on a project for nothing is challenging. And fortunately, I have a fantastic group of collaborators and some physician, scientist colleagues who are unbelievably wonderful, who had worked in ketamine beforehand. And I found myself in a very nice position here, that there were some psychiatrists who were happy to work with me, and who did not find psilocybin to be especially odd, considering they've been working with ketamine for a period of time. And in fact, I've heard before, in fact, it might have been Roland Griffiths who once said, boy, if ketamine is like, television in black and white, then psilocybin is Technicolor. And I like that analogy, but I think for physicians, psychiatrists who've been working in television in black and white, it wasn't a big leap to go to Technicolor. In fact, they're very interested to see that leap. So here I found myself in an ideal spot, and had the support of my university and some physicians to pursue this line of work. But we're working with a very, very difficult population, I want to say. where we already know the rates of dropout are quite high. The sort of standard treatment for stimulant dependence now would be contingency management, which means you pay your participants for providing clean urine drug screens. And that just shows how strong the incentive needs to be just to get people to show. And here we're asking our participants to do quite a bit more without that sort of incentive. And we're also in the Deep South, right? And the Tuskegee studies were conducted only 40 minutes away. The specter of the Tuskegee studies looms large. And Birmingham, the city of Birmingham is more than 70% African-American. And I am a white researcher in a state where there's a history of racial injustice and segregation and strong skepticism of science, thanks in part to the Tuskegee studies. So, we understandably have a lot of work to do to gain our participants' trust and ensure them that this idea is not completely insane. So here I'll talk about results from the first 10 participants who completed participation, and they were unblinded because my data safety and monitoring board wanted me to do so. I ordinarily would not have unblinded the first 10, but there was some discussion about including a crossover condition. We ultimately opted not to do so. But we do have data on the first 10 participants. So some inclusion criteria to discuss. Our participants have to be at least 25 years old. So the general idea is that one concern might be precipitating a psychotic break among those who are genetically predisposed. If we recruit those who are at least 25 who report never having had a psychotic break, it's very unlikely that they will pass the age of 25. We want them to be dependent on cocaine, no other substance dependent diagnoses except for tobacco. We want them to, when we speak with them on the phone, tell us, hey, we want to quit using once and for all, never use again. So they have to endorse a goal of complete abstinence, which everybody does anyway. We want them to be in good general health. So we conduct a very basic physical exam, an EKG, and a blood panel. I would say for the physicians on the call, in my view, as a psychologist, so take this with a grain of salt, the only concern would be a very serious heart condition that might otherwise preclude, moderate exercise. We know that psilocybin can increase heart rate and blood pressure, likely due to the sort of psychological subjective experience. It can be anxiety provoking. But if these are folks whose hearts aren't quite healthy enough to, endure a increase in heart rate by about 20 beats per minute, and they probably shouldn't be in the study. So if somebody had a very serious arrhythmia, for example, we wouldn't include them in the study. In some cases, there have been some folks who are HIV positive and aren't adherent to their medications, and their blood panel would indicate as such, and we tell them that they need to be adherent to their medications before they can move forward, because obviously we don't want anyone dying in the course of the study. We exclude people with any other psychiatric diagnoses, and at the moment, anyone who is currently using antidepressants or antipsychotics, or in general, any medications with serotonin activity would be excluded. That's, I think, something the field needs to answer is what exactly might psilocybin do if somebody is, currently on an SSRI. There was a recent publication on MDMA and some indication there that even those who had tapered off SSRIs had something of a muted response to MDMA. And I think there's some good reason to believe that those who are currently using SSRIs might show a muted response to psilocybin. And even with tapering, if someone has, used SSRIs for a good period of time, there might be sort of a chronic muting of response, which would suggest perhaps a larger dose is necessary. For now, we just exclude those people from participation. And then anyone with a personal or family history of a psychotic disorder is excluded as well. So, okay, here's where things get complicated. Try to follow me here. This is an overview of the protocol. Even I have to remind myself of this every now and then, and I've designed it. So if you don't quite follow me, that's okay. So before treatment begins, we have folks come in for a baseline assessment. We make sure they're not hypertensive. Now, for those who are, we encourage them to see their primary care provider and get their hypertension under control. Some people just don't have that option, and they would be excluded from participation. in the Deep South, hypertension is a big issue. Obesity is a big issue. Physical activity is a big issue. So, a fair number of people have not been able to move forward because of hypertension. Now, some people have said somewhat comically that, hey, if these are folks who are healthy enough to regularly use a major stimulant, you'd think they could be administered psilocybin one time and be okay. And I generally agree with that idea. But as many of you know, there's a mandate to ensure that no one is harmed as a result of their participation. We have a medical exam, and once they've cleared their medical exam and they appear to be healthy, they initiate treatment. And this is the preparation process. We have 4 preparation meetings over the course of 4 weeks. So they meet with us once per week over 4 weeks for anywhere between an hour or 2. Now, there are really 2 purposes to these sessions. We first are mostly trying to establish rapport and alliance, right? So we'd say that these should be client-centered. We recognize that these experiences can be, profoundly meaningful and or frightening. And it's important that our participants feel that they trust us entirely. One of the better predictors of experience with a psychedelic would be one's ability to immerse themselves in the experience, to surrender completely to the experience. And we want to get to the point where they feel so comfortable with us that they can completely surrender and immerse themselves in that experience when that time comes. And, I'd say, easier said than done. Some of our participants who feel completely at ease with us, who trust us unconditionally, and who go into that experience having been prepared for every potential outcome, still find themselves frightened, at least for a period of time. And I often liken this to, bungee jumping or skydiving. So you could train yourself to go skydiving or bungee jumping. You completely trust the instructors. You know that your equipment works. You know that you've done everything by the books. And yet when you're standing on the precipice of that bridge or the airplane and you look down, you still find that you are very frightened, that you're terrified, and that you may not want to jump, even if cognitively you can grasp that everything will be okay. These experiences can be very intense, as many of you probably know. And, we want at least to have done everything we can interpersonally to ensure that our participants are as ready as they can be. And that if they do struggle, they feel they can rely on our emotional support to surrender and immerse themselves. And, these are a fair number of preparation sessions, but given the sort of issues I just mentioned here, being in the Deep South, I felt that these number of sessions were warranted, but perhaps in other populations, we could work with fewer preparation sessions. Perhaps in the future, we'd have some way of quantifying readiness to surrender. Right now, it's mostly based on, clinician judgment, but everybody gets 4 preparation sessions. And generally, we feel after those 4 preparation sessions, our participants are ready. We also provide empirically supported and manualized cognitive behavioral therapy for coping with cocaine urges. And that's provided so that, in essence, our participants are getting the sort of skills needed to better cope with the urges to use. Now, I will say we include an MRI component in the study. I won't be providing or presenting those data today. And truth be told, that is not really my forte. My colleagues in psychiatry are very interested in imaging. Adrian Lottie is one. And I'll be brushing up certainly on MRI data as we begin to analyze it. But we have that component, and we are interested in default mode network functional connectivity, as well as GLX, which we assess via MRS. And to give you a sense of the population, we've had a few participants who we've not been able to scan because they have bullet fragments in their body. And we have a very powerful magnet, and people with bullet fragments, generally we cannot scan. Okay, so we administer our drug in a clinical research unit. So not in my lab space, but just across campus in a clinical research unit where we have essentially outpatient hospital rooms. And I try to dress up that room so that it has a comforting sort of living room-like feel, right? I've avoided any, religious imagery. So it doesn't look like a Zen garden as you may have seen sometimes in the psychedelic world. I just wanted to be comforting. So I have a beautiful Persian rug that was given to me by my father on the floor. I've got, some images of nature on the walls. Nothing out of the ordinary, but it's just designed to provide a more calming look than a sort of sterile hospital room. And there we administer either 25 milligrams per 70 kilograms of psilocybin or diphenhydramine, which is our placebo comparator. So that's an antihistamine found in Benadryl. And we administer 100 milligrams of diphenhydramine, which is enough that there would certainly be something that our participants would notice. I think an issue in this line of work is really what a suitable placebo might be. I don't know that we'll ever have one. I think that's okay. Maybe high dose THC could do the job, but it may just be that there's no way to completely blind both the participants and the researchers to condition. So we spend about 8 hours with our participants over in the CRU. We have them lying down, wearing eye shades, listening to music on headphones. The playlist is the same playlist that Bill Richards developed at Johns Hopkins. And for those of you who don't know Bill Richards, really amazing clinician. Bill had worked with Walter Pankey at Harvard back in the day, and also Stan Groff in Baltimore before working with Roland a bit. And so the music is primarily classical music. And a funny little story, when I was pushing this through my own IRB, I was asked as to the content of the music playlist. And it was a little puzzling to me. I'm not sure how this is an ethical issue, one that IRB should be concerned with, but the gentleman on the IRB, a physician, said, well, okay, look, I realize this is sort of silly, but if you have them listening to Mozart and Bach and Beethoven, that's fine, that's okay. But listen, if they're listening to the Grateful Dead, then I might have to take exception. And kind of funny, because I could have said, now, why exactly would the Grateful Dead music be an ethical issue? And if I want to have them to listen to nothing but extended Grateful Dead jams, maybe that's my call. But fortunately, the playlist that Bill developed is mostly classical music, and the path of least resistance was to say, oh yeah, look at this, plenty of Brahms and Bach and very orthodox, beautiful classical music. So there should be no problems. We typically, the day after drug administration, we scan brains again, and we begin the integration process. And this is perhaps a fancy term for simply discussing with our participants the nature of their experience. What happened? For most of our participants, the message is very clear. If they've received psilocybin in particular, they've had some very powerful experiences that suggest to them it's time to stop once and for all. But not everybody. And that's what's interesting about these transcendent mystical type experiences. Sometimes the subjective experience, the message is loud and clear and there's no ambiguity. Sometimes it's just a bit bewildering and frightening, and they need a little bit of help making sense of what's happened. Sometimes the content is not immediately interpretable, and they need a little help making sense of that. And my own background is as a cognitive behavioral therapist, so I've never done dream interpretation. I'm not a psychodynamic clinician. I'm not a psychoanalyst. So whatever sort of integration we do tends to be very practical and straightforward. How do we make sense of this experience? How do we apply this to your life moving forward? What can you take from it? And what do we need to change based on what you've learned from this experience? We continue to work with our participants in follow-up sessions for 4 more weeks. We continue to provide that cognitive behavioral therapy, and then we terminate treatment. After which we do assessments only 90 days and 180 days after the end of treatment. That's what EOT stands for, EOT. So before moving on, does anybody have any questions about the protocol?
Yeah, we had a couple questions about it. One was, I guess you may get into this, but what was the demographics of the first 10 that you'll talk about?
I will show you in the next slide.
Okay, how about any particular type of CBT that you use in those prep sessions?
Yeah, it was developed by a group at Brown, Peter Monti, and it's so the concepts are very practical, very sort of textbook CBT. So it's essentially about avoiding people, places, and things associated with use, and developing alternative responses to urges. So, hey, when you have an urge to use, let's see if you can stop and remind yourself why you want to be clean. Stop and remind yourself all the negative consequences that will come from using. Can you call a friend? Can you get outside and take a walk? Can you, the essential idea is the outcomes of cocaine use anyone should want, right? So when I say that, if you've had a bad day and you're feeling sad or anxious, you want that anxiety and sadness to go away. That's perfectly understandable. Cocaine is essentially allowing them to cope with those negative emotions. Wanting to cope with those negative emotions is perfectly understandable, but we need to come up with a more adaptive response. So instead of using cocaine, can we read? Can we do something you enjoy? Can we call a family member? Can we get out of the house, walk around, and so on?
Yeah, so it sounds like a combination of psychoeducation, collaborative brainstorming, and motivational interviewing, CBT.
Yeah, I mean, I think the spirit of motivational interviewing now is in almost everything we do. And we do a lot of reflective listening, and we really try to be as empathic as we can. I think that's a big part of client-centered sessions. And motivational interviewing really is an outgrowth of client-centered or humanistic therapy. So there's a lot of that at play. I mean, there's a lot of Carl Rogers at play here. And certainly during the preparation, I probably put more emphasis on that empathy and reflective listening and client-centered therapy than the CBT, which is more about the basic skills that people might need to attain abstinence or reduce the frequency of their use.
Got it. And then last one real quick before we move on is if you could say a few words about was it you in the room with a colleague who was who were the therapists? Was it a dyad? What were the qualifications or training for the therapists?
So I've been the primary therapist, which I think is probably necessary for a pilot trial with a shoestring budget, though certainly my own hypotheses and biases could influence our outcomes here. I'm aware of that. The co-guide has been either my postdoctoral fellow who is a marriage and family therapist, or a trained clinician, doctoral level clinician. I've also had a psychiatrist, a senior resident, sit in with me on a few of these sessions, and he's absolutely fantastic, very empathic. And I would say that perhaps one of the keys to being a guide is being very empathic prior, and then in the moment, I would emphasize how important it is to stay calm, because often participants, especially early on, might be very anxious. And I use a lot of analogies here, but it's somewhat like getting in a rocket ship and blasting into outer space. And in that first hour or so, the participants might look around and everything's loud and shaking, and they wonder, what in the world did I get myself into here? And if they look over at you for some reassurance, and your reaction is, oh, what's wrong? They're only going to, of course, get worse. But if you stay really calm and they want to know what's happening, and you say, hey, this is great. This is exactly what should be happening. And hey, lucky you. Looks like you're going to go on a ride. I wish I were in your shoes right now. That can help quite a bit. Sometimes it's just a matter of, some kind of appropriate hand holding and telling them, just remember, trust, let go, be open, surrender, immerse yourself in this experience. Everything will be okay. So it helps to be very calm in that moment. And, I can give you another funny anecdote. The very first participant I ever administered psilocybin to had a rather intense experience. And at one point she took off her eye shades and said, okay, hey, I'm ready to go home now. This is maybe an hour into it. Call my husband, have him come get me, ready to go. And I said, you've really only just begun. So it's not time to go home yet. And there's this interesting sort of effect with time dilation that seems to happen early on, where after an hour, some participants think they've been there all day. I told her, no, we've only just begun. And she said, okay, understood. But after a few minutes, took her eye shades off again and said, hey, I'm ready to go. I'd like to go. I don't want to be here anymore. Just call my husband. I'll tell you about it tomorrow. I don't want to do this anymore. I'd like this to stop. And that's something of a common reaction. There's probably in that moment this sense that if I just leave this place and go home, everything will be okay. The process will stop. And, it helps to remind participants sometimes beforehand, I should say, that, whether you're here or there, the train has left the station, and, the process really can't be stopped. And where you are right now is the best place to be. You don't want to be home. This is the best place to be. In any event, she was anxious, I think it's safe to say. And she said, well, what's happening to me? What's going on? What's happening to me? And this was, again, the first participant I'd ever given psilocybin to. So, I was like a duck, like above the surface, I was very calm, but beneath I was, paddling like hell. And, some thoughts that may have come into my mind at the moment was, well, I guess we'll be the site that has a participant run off into the street and, get hit by a car, and there'll be, media coverage about how crazy psilocybin therapy might be, and I'll be the investigator to bring this line of research down. That sort of catastrophic thinking that can happen in the moment. But we remained very calm, and she was able to let go once we reminded her, just remember to let go into this experience, immerse yourself, surrender. And she started to weep very cathartically, and she did that for a good period of time. While all of this was happening, I got a call on my phone from my DEA agent saying, we're here for our surprise visit. And I said, well, now's not the best time because I'm with a participant, and we can't really go through this right now. And they said, well, that's perfect. We can come on over to the room and stick our heads in the room and make sure everything is going as it should. This was not ideal. You consider the political environment we're in now. These are white law enforcement agents. My participant was an African-American who had not had a wonderful history of interactions with law enforcement. And she's also having a rather, intense experience. And I pushed back as best I could and told them, ultimately, you can come on over, we can move the door back, you can stick your head into the room for a moment, but then you have to go. And they agreed to that. And my participant, fortunately, never knew that the DEA was very briefly in the room, and I never told her. But that was quite an experience for me, and it helped to just try to stay as calm as I could. I've gotten a bit better, but I will say that these experiences in the first hour or two, I'm always very vigilant, and it seems like a good amount of work at first. Should I continue?
Please, yeah, thank you.
Okay. So demographics. Of the first 10, 6 received psilocybin and 4 placebo. And you can see that we have a fair number of men, consistent with the population here at Birmingham, primarily African-American. Half have a high school degree or less. A fair number are homeless. See that half make less than $10,000 per year. About half are unemployed, and the mean age is mid-40s. Let's get into first the challenging experience questionnaire. Okay, so this is a questionnaire that assesses the sort of difficulty that one might experience during a transcendent mystical experience. And to give you some context, there are adjectival anchors associated with each number here. So a 0 would be, nothing at all, none. A 1 would be, very slight, so slight that I can't quite tell. A 2 would be mild. I think a 3 would be moderate. A 4 would be very strong. And then a 5 would be, extreme, strongest I've ever had in my life. So among those who receive the psilocybin, none of these differences are statistically significant, but at the ends of 10, your eyes can probably tell you what's happening here. It does seem like there's a trend where those who receive psilocybin report stronger, challenging experiences. But note that even for the scale where that is strongest, this is for fear, it's somewhere between so slight I can't tell and mild. And I think this is in part because when those difficult experiences do happen, they tend to be pretty brief, right? So again, you might say that you were scared when you went skydiving or bungee jumping, but it was really only briefly before you jumped. And for the rest of the experience, it was just, incredible. And when you finish, you don't so much remember that fear that was brief at the beginning, but you remember everything else that followed. But people, do do struggle a little bit, but they generally tell us that it was either slight or mild. But now let's go to the mystical experience questionnaire, which uses the very same scale with the same adjectival anchors. All of these differences are statistically significant, by the way, and the effect sizes are massive. So, psilocybin does what we would expect it to do. It's ineffable in part. It's difficult for people to describe with words the experience they've had. And, 4 again would be very strong. So they're not saying it's the strongest I've ever experienced in my life, but it's very strong. Is it transcendent? Were they in some realm beyond time and space, to some degree? It's interesting administering these self-report questionnaires to a population that's lower SES that may not have a great deal of formal education. That my clinical experience is that they very often don't completely understand what these questions are asking, and that makes sense because they were developed by religion scholars with PhDs in divinity, and the wording, sometimes I just shake my head and think, my God, how could anyone who developed this think that this would be understandable to someone who doesn't have at least a master's degree? With positive mood, those who receive psilocybin are saying it was either very strong or the most extreme experience they've ever had in their life. And the same would be for the mystical scale, which sort of gets at that idea that we're all one. There's this unitary consciousness. There's no me, there's only us, and I'm integrated with everything. So psilocybin is doing what we expect it to do. We ask people also, how personally meaningful was the experience? And we see that of those who received psilocybin, 2 said it was the single most meaningful, 4 said it was in the top 5. One of our participants who received placebo said it was the single most meaningful of his life. And this speaks to the placebo experience. Also, this participant, I know them all well. He had spent a fair number of years in prison, and upon his release, he was in the drug trade. He was a well-known figure, and upon release, he was something of a wanted man, and certainly didn't rest easy. It wasn't easy for him to really ever walk down the street without looking over his shoulder. So to be in a room where he could relax and listen to this music, for him, it was a very meaningful experience. And I don't doubt, relative to everything that he experienced, that it was. We also asked how spiritually significant the experience was, and half of those who received psilocybin said it was the single most spiritually significant experience of their lives, with another one saying it was in the top 5. And for those who received placebo, no one endorsed either of those 2 responses. Okay, so follow me here. This is our main outcome. Percentage of abstinent days. We want to see that number increase. Can you see my cursor or not? I don't know.
No.
Okay.
Oh, there it is. Yeah, I can see
okay,
that.
Good. So here, this is when we first see our participants. How frequently are they using? Or how frequently are they abstaining? You can see here that they are using, about half of their days. Often the only limiting factor is finances. If they had enough to use every day, they would. And some people who are on some assistance might use all that money at the beginning of the month, then not use for the remainder until they have money again. Now, what we want to see is for these, the percentage of abstinence days to increase. And we see here where it says pre-2 to P1. So this would be the period of time once they've become participants, but they have not yet received any psychotherapy. There's no treatment. And we would expect to see this change. So people are ready to change. They've entered a treatment program. And before we've done anything for them, they start reducing the frequency of their use. That makes sense. That's consistent with the literature. This next period of time would represent the period of time that they're receiving that cognitive behavioral treatment, but we have not yet administered a drug. And here too, we see an increase in the percentage of abstinent days, as we would expect, but no group differences. Here's what we're really interested in here: the period of time after we've administered the drug and the end of treatment. And you'll note that there is no error bar around this red diamond, which means all 6 of those psilocybin participants reported 100% abstinence during that time. There was no variability. Every single of those 6 individuals who received psilocybin reported no cocaine use whatsoever during that time. That wasn't the case for those who received the placebo. And although any statisticians here, I apologize that I've conducted the test. I just thought it would make for a more interesting presentation. A statistician would say with an N of 10 without complete data, you shouldn't bother, but I did anyway. And already this is a statistically significant finding. That's what the p-value indicates. Anything below 0.05 is statistically significant. And this D is a measure of effect size. So it tells us how big is the effect. Anything above 0.8 is considered large. We typically don't see large effects. So this is more than double what's considered to be a large effect. There is, a slight dip in abstinence among those who received the psilocybin from the period of time after treatment ends until 90-day follow-up. Same we see in the placebo condition. And that difference is not statistically significant, but close. And then there's a rebound here from the period of time after the 90-day assessment to the 180-day assessment, where every single participant who received psilocybin reported 100% abstinence during this time. And a nice, a higher rate of abstinence among those who received the placebo. I think we could say that these are very motivated participants who were able to go through a very rigorous treatment, and they may not be entirely representative of the population of cocaine users. I think that's something that people like us are dealing with, right? Whether this would apply to the population of individuals who may not be able to go through this treatment program is something we may never know. But we see that this difference is statistically significant and the effect size is massive. But listen, take this with a big grain of salt. This is only 1/4 of the data that we've collected, and this trend could reverse. And I will say, kind of as an aside, I think the media coverage of psychedelic research or therapy has been overly positive. And, in part that's designed to sort of reverse some stigmas and to, generate some support from the public. And I understand that, but, I think if we're objective, we know that this treatment paradigm certainly won't work for everybody. For some people, it may not have much of an effect at all. And for some conditions, it may not be effective. So we'll have to see whether these trends continue to play out. I hypothesize that they will, but if they don't, I'm happy to report that as well. A few other things. This is the severity of dependence scale. So we're now not just capturing how frequently they use, but the degree to which use is interfering with their lives. And you'll see that the groups are very similar at their first preparation session, so intake. And there's a decline right at the first MRI before we've administered the drug, but no group difference. When the error bars don't overlap, you generally know that you have a group difference, you're close to having one. After we've administered the drug, at the second MRI, we're already seeing a difference or nearly a difference between these conditions. And among those who received psilocybin, you see that there's a decrease in the degree to which the drug is interfering with their lives subjectively to 0 at the final follow-up, whereas there's something of a rebound among those who received the placebo. And this is exactly what you would expect to happen when the behavioral treatment is withdrawn. So there's a reduction in the severity of dependence that then rebounds once treatment ends. And you can see here that there are statistically significant differences between conditions with effect sizes that are massive. But again, as I said, we don't know if these trends will continue. I'll just say a few other things. This is a scale that measures withdrawal symptoms. We see a nice decrease in both conditions. It maintains low through the end of treatment. However, it rebounds among those who received the placebo and stays low among those who received the psilocybin. And I think one explanation for this is that the individuals who receive psilocybin generally aren't using. And if you're not using, you're not going to experience withdrawal. I thought this was interesting. This is expected difficulty in quitting. So we just asked people, how difficult do you think it'll be to quit using cocaine on a 0 to 10 scale? And there are no differences between the condition until immediately after they receive the medication, in which case those who receive psilocybin say, I don't think it's going to be difficult, I can do this. But those ratings generally remain high. And they're a little variable here because our N is small, it'll even out. But you can see that even through the last follow-up, there's this big difference where, you might say those who receive psilocybin feel more confident in their ability to remain abstinent. Some of you here are interested in depression. Our goal here was not to target depression, but certainly, negative affective disturbance is a big issue with people who are dealing with a substance use disorder. Now, there could have been some, group differences before we administered the medication here. You can see at this first MRI, there would not have been, this is not statistically significant, but again, your eyes might tell you what's happening. We had not administered any medication here, so it could be that those who received psilocybin were, less depressed than those who received the placebo. But in any event, you see that there's a decrease in depression with a slight rebound here at the end, with a number of group differences at some of these follow-up points. And I think that's notable, again, because we didn't target depression specifically, but there seems to be an antidepressant response. The last thing I'll show here is a measure of life satisfaction. Again, there could have been some group differences before we administered the medication, but after, there were some pretty substantial group differences that really were maintained through final follow-up. Now, a lot of that might just be because people who receive psilocybin have mostly stopped using cocaine or reduced the frequency of cocaine use. And I don't doubt that, but in addiction trials, there has been a call to attend to more than just the drug use outcomes, but to determine the degree to which the treatment could affect other things. And this tells us a little bit about how their lives may have changed as a result. Okay, so that's my last slide. Of course, I have my acknowledgement slide here, but in the interest of time, I'm happy to take any more questions. I'm sure there are some.
Yeah, well, thank you so much, Dr. Hendricks. It's always the awkward part because we're all clapping internally, but you can't hear it, or I'm clapping at least. Thank you. That was fantastic. I have to jump in. I mean, my burning question is, how is this not funded? You mentioned a shoestring budget, and stimulant abuse is an enormous unsolved problem. How is it that well, that's just maybe rhetorical, but that surprises and disappoints me that it's not funded.
So consider this. In 2006, when Roland and his team published the data he published, he used some funds that were given to him from NIDA, the National Institute on Drug Abuse. They were discretionary, which meant he was free to use those funds however he chose. The director of NIDA at the time, Nora Volkow, who's the director now, wrote an open letter to the public that said, hey, just so everyone knows, psilocybin is a hallucinogen. That's not my preferred term. The hallucinations are not frank hallucinations. That only begins to capture what people experience. But in any event, she said, hey, this is a hallucinogen and it's dangerous. And, Dr. Griffiths did use funds from NIDA, but we didn't specifically approve this study. He was, free to use them as he chose. And we don't think anyone should be doing psilocybin. I think that kind of tells you a bit about where things are still politically. It's a difficult sell because the directors at NIDA still ultimately do report to Congress, and I think we could all agree that politically things are just a little crazy right now still. And I think that my heart goes out to them. They would ultimately have to go before Congress and say, yes, we have earmarked funding for a hallucinogen to treat cocaine dependence, or for a hallucinogen to treat opioid dependence or tobacco dependence. It's still, I think the optics are not necessarily in our favor. I think that could improve with time. I hope that it will, and I think the other NIH divisions are going to be a little more open to funding this, but it's going to take a little bit of time for things to change. Now, many of you may know that AOC had introduced an initiative that would, she felt, make psychedelic research a bit easier to conduct. And the co-sponsor of that initiative was Matthew Gaetz, who's sort of a well-known Trump loyalist in Florida. So there is support across the political aisle. And Senator Schatz from Hawaii has asked NIH, hey, where's the funding for this line of work? So I think that will come. I think NIMH or other divisions are going to fund this work before NIDA does. And that's because essentially we're asking NIDA to fund studies as to evaluate a drug of abuse with a sort of noted history as a therapeutic for addiction. And it's just going to take a little while before they feel comfortable doing that. Hopefully, after I finish collecting my data, they'll be open to it.
Yeah, I mean, it seems like that just speaks more to the importance of this early data as chipping away at that.
I think so.
Yeah, so a bunch of questions. One, I think might get at a few different things. Just so, when you use psilocybin for depression, we rely sometimes on self-report, and it's kind of a wishy-washy thing, and it's subjective. Addiction is different. Addiction, a person, there's things a person is using or not using, or, and you got at that with different things. I think the withdrawal measurement speaks to this, augmenting how you measure it. Just, we're curious, like, did you ever do random U-toxes to confirm abstinence?
Oh, yeah, I should have mentioned that. So every single time they see us, they're providing urine samples, which is, of course, lots of fun for me because I'm collecting urine samples all the time. And, I still think this is an issue. If we did a smoking cessation trial, we could biochemically verify tobacco use with expired breath carbon monoxide, but that would only capture tobacco use really in the past 24 hours. And there's not widespread agreement on what the proper cutoff should be. We could use something a bit better called cotinine, assessed in saliva or urine or plasma. But even then, that only extends the window maybe 3 days. So in smoking cessation trials, we're mostly relying on self-report, and the biochemical verification produces this effect known as the bogus pipeline. And the idea there is, if the participants think you will know objectively if they've been using or not, they're more likely to tell you the truth. With cocaine, the best test we have really is the urine drug test, and that window really varies depending on the individual's kidneys and how efficient they are. For some people, we can detect use within a week. For others, maybe only within 3 days. And many of our participants have been in the criminal justice system, and they are extremely smart and wily, and they know exactly how long they have before the cocaine metabolite clears their system. I've had to go out of my way really to tell them, listen, your participation is confidential. I am not going to share this with anybody, not your probation officer, not your parole officer. No one will even know you participated in the study. But I think, for a population that lives a difficult life, a chaotic life, and one where they've had involvement with the criminal justice system, where, quite unfairly, rather than providing treatment, we just punish addiction in a very draconian way. It can be a shift to suddenly being very honest about their use. So, we're still dealing with that issue. We're relying on self-report. It's not perfect. I think as long as we don't see a confound between the conditions, as long as we don't think that suddenly psilocybin will affect the degree to which people are willing to be honest, then we can be confident in our findings. But it's very interesting to me, and I've thought of this just anecdotally. There seems to be something to this idea of vulnerability. If you're familiar with this idea that in cultures that have a degree of toxic masculinity, people often don't want to admit to having problems, right? They'd say everything's great. I can quit whenever I want. No problem whatsoever, and they might sort of underreport their usage. One question might be, if you have this intense experience with psilocybin, might you suddenly be more honest about your use? I mean, I don't know. I think this is an important research question, but I wouldn't be surprised if we see that sort of thing, only because clinically what I've noticed is that often the people who it would appear receive placebo and continue to use still tell me, but yeah, I can quit whenever I want. I'm totally confident in my ability to do it. No problem. Whereas, one of our participants who stopped using and never used again, when she came back to see us for long-term follow-up, told us she was not at all confident she could resist the urge to use. And when I asked her about that, she said, well, this is sort of the key to my being abstinent. Okay. If I assume I cannot resist the urge to use under any circumstances, then I will never put myself in a dangerous situation. And that's how I've gotten to the point where I, am completely abstinent. And if you just looked at our self-report findings, you would think, well, hey, maybe those who received, if this is a trend, maybe those who received placebo somehow benefited more than those who received psilocybin. But it might just be that those who receive psilocybin are suddenly just a bit more vulnerable and honest about how they're doing. So we'll have to see. I think that's a great research question moving forward.
Yeah, it's a great way to get into the complexity of it. Something that's maybe missed by the scales a little bit alone.
Yeah.
One question a few people had is, you showed those really dramatic differences in the components of the mystical experience between the small number of placebo versus psilocybin. Just any thoughts on that as the central mediator of change, or that versus awe, or just in your conversations with participants, any hypotheses or early thoughts on what is going on that's mediating these effects?
That's such a good question. And I can't tell you how many times I've just wrestled this idea in my own mind. So I'll give you a couple stories that really were quite profound to me. We had one woman who, in her experience, saw her life as if it were a fresco or a frieze. It's a piece of art that would tell a story beginning, middle, and end, but you can see it all at once. So she could see her life all at once, where she was in the past and where she is today. And she was able to, in this experience, she said, track back to this moment when she was a child that she felt was critical in leading her to cocaine use. And it was having been sexually assaulted, molested by a family member as a child. And she went back and she said, that's where it all started. That's where it started. And I blamed myself for what happened. And I felt shame for what happened. I felt it was my fault. And I cope with that by using. But what I did was I went back to that baby version of me, that young child. I mean, I think she was maybe 9 or 10. I went back to that child. I saw that child version of who I was. I embraced her and I said, it's not your fault. It's not your fault. You should not feel shame for this. And the path that you're going to take, that path of cocaine use, is not the path to take. Don't do that. And in that experience, she took this new path that led her to where she was today, someone who she felt was now a non-user. I mean, dramatic, amazing experience. And she never used again. We had another participant who, very deeply religious person, an ordained minister, and he had this vision of being embraced by Satan, sort of your archetypal image of Satan with wings and horns and a tail, and Satan had his claws sunk into him. And this participant was terrified. And he said, he wanted to go. He didn't want to be there. And he said he even looked over at me at one point, and he joked about this afterwards. We had a very good rapport, but he said in the moment, I looked over and I thought, man, what did these white guys do to me? Is this another Tuskegee experiment here? This is crazy. I want to go. But he remembered what we had talked about, looked at me and said, you know what? That's Peter. We're okay. I'm just going to go into this. And he told himself, if you've heard about this notion of ego death, well, if I'm going to die, I'm going to die. I'll just let myself go. And he said after that, he asked Satan to release him from his bonds. And what followed was light and redemption and beauty and rejoicing. And he was singing and weeping and singing and crying. And he felt like, wow, Satan's embrace was, essentially my addiction to cocaine. And I was released. I was rescued. For those of you who are familiar with this story from the Christian New Testament, he said, I was like Lazarus in the grave, just rotting away. And I've been resurrected. I've been pulled from that grave, and I'm never going back. So the experience was very easy to interpret. We didn't have to do a lot of integration around that. But then other people have said to me, hey, I'm sure I got the placebo. The music was beautiful. I enjoyed that. Not really a whole lot else to say. And this is one person I'm thinking about who told me this repeatedly. No, I got the placebo. I know I did. I don't have a whole lot to say. The music was beautiful. At one point, I thought you may have had an orchestra in the room next door because that music was incredible. But then I realized I hadn't listened to music on headphones like this in years. So it must have just been the quality of the headphones. The music was incredible, but I know I got the placebo. But meanwhile, last night, God performed a miracle and just took my urge away. It's gone. Okay. So, was there a mystical experience there? It doesn't sound like it. Now, maybe he had one and he didn't really want to report it because, we're in the deep South. There are a lot of very, very explicitly religious people here. And I can see afterwards they think, now, should I have had an experience like that with a drug in a hospital? I don't know about that. And we've had some participants who are really, frankly, just kind of terrified, didn't enjoy themselves at all. And, I think of one participant who told me afterwards, it was absolutely terrifying. I had no idea how terrifying that would be. I hated everything about it. There's no way you could ever get me to do that again. But I feel like that was some sort of rite of passage I had to go through to become a non-user. I realize that now. I want to be a non-user. And I realize that if I ever go back to using, if I want then to become clean again, I will have to go through that experience once more. And because I never want to have to go through that experience again, I'm never using again. I mean, this is what people are telling us. It's really interesting, but that's not purely mystical in the sense that there's a sense of oneness and wonder and timelessness and spacelessness. And so I don't entirely know what's going on. There's a great book by Masters in Houston written years ago called The Varieties of the Psychedelic Experience. And I think there might be more to it than just transcendent awe-like experiences. I mean, I really think of like a very profound experience of awe as being essentially synonymous with mystical type experience, but maybe there's more to it. Maybe it's just about reduction of inflammation for some people, or normalization of the default mode network. I don't know. And this is kind of interesting to be working with a substance where we're evaluating the efficacy before we completely understand what it might be doing from a mechanistic perspective. And I think it's fair to say that I may have felt very strongly that it was about mystical, transcendent awe type experiences, but now I don't really know, but I'd like to know.
Yeah, those are incredibly beautiful, symbolic, emotional experiences. So, specific to each person, and that's really cool to hear those. And we'll be waiting for your Satan's embrace hypothesis for mechanism of action.
Yeah.
Want to be respectful of your time. Maybe just if you have any, questions that keep you up at night about it. I mean, you just went over a few, but things that you're still wondering about this research, your research with cocaine dependence in particular, and anything else you'd like to leave us with before we part ways.
Yeah, well, I would say we'll probably have many decades of research trying to understand exactly what's happening here and what the moderators might be. I know already people are wondering, do we even need that mystical experience? Of course, one question would be, why would we want to engineer the mystical experience out of that drug molecule? Other than perhaps, politically, it makes for a more palatable medication. But I think the mechanism is fascinating to me. The other question would be, if we see an FDA approval and an indication, how might this look in the real world? A clinical trial like this is only designed to show that there's an effect. It's not at all designed to provide a model for real world practice. So do we need booster sessions? And if so, how frequently? I don't know the answer there. I'm convinced that psilocybin is so darn safe and relatively inexpensive that there could be, a situation in which people might come back every 6 months. But, it's certainly not something that people want to repeat. And most of our participants would say, there's no way I'd do that again. Even if it was the most meaningful experience of their lives, they don't want to do it again because it feels like running an ultra marathon. Like, wow, I just ran 100 miles through the desert. Wasn't that amazing? I feel like I could fly right now, but I'm never doing that again. So that's a big question. For me, I think those are the two big ones, right? Exactly what is happening here and how is this going to look in the real world? And the other one would be, will we get to the point where there will be public funding for this line of work? I really hope that there is. And I know there are concerns about the influx of sort of industry, but it's funny when you're trained to do what I do. This clinical trial is about as good as I can do. I can't really answer some of these big questions, but I certainly do wonder about how that might happen and whether the industry involvement will be a good thing or a bad thing. And I certainly hope that the population I work with, who are really lower income people whose lives are really difficult, will always have access to it.
Yeah, well, if there are any billionaires out there, just we'll send them your way if they're out, and I actually mean that. Being at Stanford, there's a ton of, Silicon Valley is dense with people who have too much money. Anyway,
Yeah.
but really appreciate everything you said. It's like, it's awesome to have that excitement within a balanced perspective, to be reasonable, to be curious, to get these stories, that personal flair. So thank you so much, Peter, for chatting with us. And thanks, Jennifer, for organizing this. But yeah, thank you so much.
And let me just say that anybody out there, I'm happy to answer any questions via email. I'm not sure if my email address has been shared. Jennifer, please feel free to share that. I might be a little slow to respond because I've got 3 young children and we're still in the midst of this pandemic, and that's of course unbound chaos. But I'm really happy to engage with anybody who has any questions about any of this. And I'll say to Gianni, anybody here at Stanford, one thing I really love about this work is how cooperative and collaborative it is right now. So if there's anything I can do to help with anything that's happening anywhere, I'm happy to share anything with no expectation of anything in return, other than, I hope more and more people do this work and I can play a role in sort of getting it out there.
Awesome. Really appreciate it, Peter. Thanks so much.
All right. Thank you.
Thank you.
Is this the awkward part where I just disappear?
Pretty much. Yeah, I guess we all wave and people go do their thing.
Right. Well, thanks again.
Thank
Take
you,
care.
Peter.
Bye-bye.
Thank you, Peter.